I'm Ganapati. I'm I'm an occupational therapist and I'm heading the occupational therapy department here. And also I am in the position of advanced neuro rehab specialist, which means that one who is familiar about the other department, going across occupational therapy, understand the clinical and the other department treatment methods and assessment method in a overall to coordinate different departmental activities. And I am basically from Tamil Nadu, and I have completed my schoolings from Kanyakumari district, and then I have done my undergraduation from Savita College in Chennai. So from the beginning I am very passionate about two things. One is about the child, second thing about the brain. I think 2008, and I joined in St. John's Medical College. So there I was working for about 7 years. I joined as a junior occupational therapist, and then I got promoted as in charge of the department. Some of the role which I was playing there, starting from my pediatric area of interest. So I was handling children who are high risk, who born and got admitted in neonatal ICU, who are called high risk infants. So the lowest body weight child which I handled was about 600 grams. And when people ask, what do you do for 600 gram child? That it's not about exercising the child. It is about how the child feel if the child come out that time it's supposed to come out, isn't it? It's 3 months before the child is coming out to the world. The light outside and the sound outside, the movement outside, the gravity on the body, everything is going to cause some changes in the brain, how the child feel, it's going to be different. So we have some system of therapy to make sure that prevent the complications for the child and early identify what are the probable developmental disability can happen. So throughout the 8 years, I had the experience of working with the infants in the ICU. Along with that, we have weekly twice to thrice we conduct something called neonatal follow-up clinic, where we follow the infants up to 2 years and beyond that. And one more post which I am holding here is the assistant general manager for training and development, which is the internal training model for people who are working within the PRS neuroscience, the training and the development of the quality of care which is given. I am taking care of that also. This is about me. ROS is a system, rehab operation system, which if I give you, if you are trained by us, you can run the business. So it is created for creating a system. Means without a system, everybody take their own decisions, right? So ROS has two big areas. One is administrative and a clinical. So the administrative part, that typically how the administration work. Now the biggest challenge is how this clinical module and the administration module talk to each other. And if you come to the clinical part, which I am familiar about, is like maybe the admin part, you can ask more about admin part to Nikhil. He is very well aware of it. So if you come to the clinical part, the biggest challenge what we are facing in rehabilitation is you have multiple professionals, physical therapist, occupational therapist, speech therapist, psychologist. These are all like 4 different people talking 4 different languages: Kannada, Malayalam, Tamil and Hindi, something like that. If all these people talk, you cannot get one information, right? So people are not understanding what they are telling only. So the communication is not very clear. So this is how I am seeing ROS is something which is talking the same language. So what we have done is we have converted all these domains into one outcome, that is patient's functional independence. We call it functional independent level. So there is something called functional independent measure already, everybody is doing it, but that will tell, okay, patient is performing this particular activity with minimal support, moderate support or maximum support, but doesn't mean anything. Can he brush? If he can brush, how he is brushing, which hand he is using, all these things. So, we want a functional independent level, and then under that you have subcategory. So, we call functional body level, that is like you roll, get up and sit, and then if you have to brush, you have to do all these things, go to the toilet, right, and then you have to use your both the hand, not one hand, both the hand you have to do, take the brush, take the paste, apply it. So, this is called functional upper limb level. And then you need some CVC, that is cognition, vision and communication. That means you should be able to see the brush, you should be able to identify which is brush, which is paste, what type of paste I am using. All these things, the mental processing, and you should be able to understand what is the conversation, communication, everything. So, this is called CVC. These are the three major domain which is fundamentally this FBL and full is like called sensory motor control, and CVC is your software. So, your body is also acting like a software and hardware. So, these two things are basically integrated. So, in each level you have 7 levels. So, based on this algorithm, the top 7 level will be achieved. If suppose if you say functional independent level 1, patient is able to roll, get up and sit, this is, and then perform some eating activity. So, anybody who is going to home, we will give some amount of independence something. Without going further detail into that, I am going down to this hierarchy. It's like when as you go down, it goes up to the joints, how much range, all these things in the basement. We work from all these basic things and come up and achieve the highest level. This is what ROS is doing. So, what it is actually doing is now it is talking to each department and it is suggesting you what is the next goal you have to work on. So, the therapist need not to worry that what should I work on. All these things are preset, and at the same time we are all working towards same direction. That is what ROS.